This is Dr. Chitra here, your mentor at Study EFOG, and today we are going to discuss about few important topics from the module General Gynecology. Let us first begin with heavy menstrual bleeding. So you can pause the video, read the question, think about the answer, and then click for the next so that you would know what is the correct answer. The situation we have here is a 30-year-old woman who has presented with heavy menstrual bleeding for past 4 to 5 cycles. Previously, her cycles were regular, she had moderate bleeding. For the past few months, cycles are regular, amount of bleeding has increased. No associated pain or passage of clots, no other comorbidities. So what are the investigations that you would offer her? The options are serum ferritin test, full blood count, serum FSH-LH, coagulation profile, and thyroid function tests. According to NICE guidelines, the investigation that you would offer her is a full blood count. So full blood count is advised for all women, those who present with heavy menstrual bleeding. Screening for coagulation disorders is advised only for those who have heavy menstrual bleeding since menarche, or there is a personal or family history that is suggestive of coagulation disorders. Ferritin test is not advised, hormonal tests are not recommended, and thyroid function tests are not done unless there are symptoms of thyroid disease. So what are the basic investigations that you would do for a woman with heavy menstrual bleeding? Now first, coming to the history. So it's important to know what is the nature of bleeding, whether there is menorrhagia, intermenstrual bleeding, postcoital bleeding, or postmenopausal bleeding. In addition, any related symptoms like pelvic pain or pressure, any uterine cavity abnormalities or histological abnormalities or adenomyosis or history of fibroids. How much is this heavy menstrual bleeding affecting her quality of life? Any comorbidities in the form of hypertension or diabetes, and any previous treatment that the woman has undergone. What is the role of physical exam? So if there are any related symptoms like pressure symptoms or pelvic pain, it is mandatory to do a physical examination, and also before you want to put in an LNG IUS and before you do any investigations like an ultrasound, it is mandatory to do a physical examination. Regarding to lab tests, we have already seen that a full blood count is the basic investigation. Coagulation disorders screening as indicated. Now coming to investigations. So whenever there is any history suggestive of a submucosal fibroid or a polyp or any endometrial pathology, a hysteroscopy is indicated. Ultrasound is done if there are any palpable masses like the uterus is palpable, or when upper abdominal examination is very difficult due to obesity. Let us see a few questions regarding to the investigations. Okay. So the first scenario we have here is a 47-year-old who has come with a history of intermenstrual bleeding for the past 6 months. Cycles are regular, there is no postcoital bleeding. She is using condoms for contraception. All previous cervical smears are normal. Last smear was done 1 year ago. So what is the diagnostic procedure that you would offer her? Options are physical examination required, commence first line treatment. Option B is physical exam, pelvic ultrasound, recommend diagnostic hysteroscopy and endometrial biopsy. Option C is physical exam required, obtain a cervical smear, prompt referral for urgent transvaginal ultrasound. And option D is a physical exam is required, obtain cervical smear, request FPC. Now here we have seen that she is 47 years old. Her cervical smears are all regular and they are normal. So the best option for her would be that you would do a physical exam. She has come with intermenstrual bleeding, so a pelvic ultrasound is recommended, and also because of her age she is at a high risk for endometrial pathology, so do a diagnostic hysteroscopy and an endometrial biopsy. So that fits into option B. Second option is there is a woman who has come with history of postmenopausal bleeding and the cervix, her cervical smear shows atypical glandular cells of undetermined significance. Now this lady is at a very high risk of having an endometrial pathology. So for her, again, option B is the correct option, because her cervical smear is showing glandular cells, which could be that the cells have come down from the endometrium. Now the third scenario, 41 years old, heavy menstrual bleeding, cycles are regular, no other symptoms, exam is normal, she is using condoms for contraception, and all cervical smears are normal. What would be the best option for her? For her, a physical examination not required, because she is having only heavy menstrual bleeding, no intermenstrual bleeding, no postcoital bleeding, no postmenopausal bleeding. So physical exam is not required, conservative treatment is offered, and you can commence first line treatment. So option A is the best choice. Now the fourth scenario, you have a 61-year-old with postmenopausal bleeding, last menstrual period 11 years ago, and she is not on any hormone replacement therapy. Postmenopausal bleeding, very high risk factor. So for her, option C, that means a physical exam is required. You would want to have a look at her cervix, obtain a cervical smear, because nothing is mentioned about her cervical smears, and you will promptly refer her for an urgent transvaginal ultrasound. So that brings us to this algorithm, which is telling you about the investigations offered for women with heavy menstrual bleeding. So first, take a complete history, do an examination, and do a full blood count. Now, whenever there are no additional signs or symptoms, there is no suspected pathology, you need not do any other investigation. You can offer her first line management. Whenever you have any woman with heavy menstrual bleeding, with intermenstrual bleeding, and she is at a high risk for endometrial pathology, for these women, if you are suspecting a submucosal fibroid or a polyp or endometrial pathology, always offer an outpatient hysteroscopy and an endometrial biopsy. If she declines this, you can offer her a hysteroscopy under general anesthesia. Now, any woman who has a pelvic mass palpable or the uterus is palpable, or an examination is difficult because of high BMI or whatever reason, it is likely that she has a large fibroid. So for these women, the first investigation that is offered is a pelvic ultrasound, either transvaginal or transabdominal. Now, women presenting with significant dysmenorrhea, and they have a tender bulky uterus, and you are suspecting adenomyosis. So for these women also, offer a transvaginal ultrasound. If the woman declines this investigation, only then you will consider a transabdominal ultrasound, or you would go ahead and offer an MRI. Now let us see a little bit about the management for heavy menstrual bleeding. So you have a 48-year-old woman with 3 years of heavy menstrual bleeding. She has had 3 normal vaginal deliveries. Cycles are regular but they are heavy. BMI is high, 39. And a transvaginal ultrasound shows an endometrial thickness of 8 millimeters, and she has 3 intramural fibroids, but they are less than 3 centimeters each. What is the next most appropriate step in her management? So plan for lap-assisted vaginal hysterectomy, arrange for pre-op assessment for abdominal hysterectomy, counsel for endometrial ablation, insert an LNG-IUS and follow up in 6 months, or perform an endometrial sampling. Now here, this woman, for her, the best option is perform an endometrial sampling. Why? Because she has risk factors for endometrial hyperplasia. Okay, her BMI is 39. Endometrial thickness is increased on a transvaginal ultrasound. So first thing that you would do is do an endometrial sampling, rule out any endometrial pathology, and then plan her for any definitive management. So management options for women with heavy menstrual bleeding. Okay, what are the options that you have? You can offer tranexamic acid, you can put in an LNG-IUS, You can offer a hysteroscopic myomectomy, or a second generation endometrial ablation can be done. You can offer an hysterectomy with or without a bilateral salpingo-oophorectomy, offer combined hormonal contraception, uterine artery embolization, or you can offer GnRH analogs. Let us see a few scenarios. So you have a 45-year-old woman with heavy menstrual bleeding, multiple uterine fibroids. She is planned for a hysterectomy, but after 3 months because of some personal reasons. So the obvious choice here is you will offer her GnRH analogs, because for the 3 months you do not want her to keep on having a menstrual cycle and keeping on bleeding. And plus the GnRH analogs will reduce the size of her fibroids and make hysterectomy easier. You have another 45-year-old with heavy menstrual bleeding that is not responding to medical management. She doesn't have any other pathology, but she wishes to retain her uterus. So what can you do for her? She's 45 years old. You can offer her second generation endometrial ablation. Okay? Because her endometrium is not showing any other pathology. And she wants to keep her uterus. Okay? Now another woman who is 30 years old, heavy menstrual bleeding, no other symptoms, physical exam is normal. But for her, what would you do? For scenario 3, the option is B. You would put in an LNG IUS. Because she is only 30 years old, we do not know whether she has completed her family or not. So you will offer her conservative management, and LNG IUS is the first choice for any woman who is presenting with heavy menstrual bleeding. Option 4 is the same as above, but this woman is interested in conceiving. So if you put in an LNG IUS, obviously it is going to serve as a contraceptive. So here the treatment of choice would be tranexamic acid till she achieves a pregnancy. Now you have a 35-year-old with heavy menstrual bleeding. Her family is complete. She doesn't want to put anything into her uterus and she doesn't want surgery. So what is the other option that is available? You have combined hormonal contraception that you can give her, because she is still young, 35 years old. She says that she has completed her family. She doesn't want anything in her uterus. She doesn't want any surgery. So combined hormonal contraception would help her out. Now you have a 30-year-old with heavy menstrual bleeding and she has a 4 centimeter submucous fibroid. So a submucous fibroid, what would you do? The obvious choice is you would offer her a hysteroscopic myomectomy to remove the fibroid. This brings us to this algorithm for management of women with heavy menstrual bleeding. So whenever you are offering any management options, you have to take into consideration whether they want to retain their fertility or the uterus, what are the benefits and harms of treatment, and whether they have any comorbidities like multiple pathologies, and what is the size of the uterus. Now, when there is no identified pathology, or there are fibroids but they are less than 3 cm in size and there is no adenomyosis, so if the symptoms are not very severe, the first option is LNG IUS. If that is declined, then you can offer tranexamic acid or NSAIDs, or you can offer hormonal treatment in the form of combined hormonal contraceptives or cyclical oral progestogens. Now, if this woman has severe symptoms, you would refer her to specialist care, or any woman who has had an LNG IUS or any medical management that is not alleviating her symptoms, then refer her to specialist care, where they would do investigations for her and they would consider surgery in the form of second generation endometrial ablation, or they would offer her a hysterectomy. Any woman who has submucosal fibroids, consider her for a hysteroscopic removal of the fibroids. The other scenario, there are women with heavy menstrual bleeding with fibroids that are more than 3 centimeters. So, ulipristal acetate could be one option, and the other option is to refer her to specialist care. So, in specialist care, they would consider surgery in the form of myomectomy or hysterectomy. Prior to that, you can give pre-treatment with GnRH analogs. You could also consider uterine artery embolization, but you have to inform these women that pregnancy would not be very safe after uterine artery embolization. The third option for women with fibroids is you can give second generation endometrial ablation. So these are all the management options that are available for women with heavy menstrual bleeding. Now let us next come to abnormal uterine bleeding. So what is abnormal uterine bleeding? This is any bleeding, any menstrual bleeding from the uterus that is either abnormal in volume, that means the duration is excessive or it is heavy. There is distortion of regularity, timing, so the bleeding could either be delayed or it could be frequent, or the bleeding is non-menstrual. Okay, and any woman with abnormal uterine bleeding, the adverse outcome is greater in women in whom the total menstrual blood loss exceeds 80 ml or the duration of the menstrual cycle is more than 7 days. Now, what are the causes of AUB? So you have the Palm-Cohen classification for this. In this, P stands for polyp, A is adenomyosis, L is leiomyoma, and M stands for malignancy and hyperplasia. C is coagulopathy, O is ovulatory dysfunction, E is endometrial causes, I is iatrogenic, and N is not yet classified. So if you pay careful attention, you can see that the components of the PALM group, they are discrete structural entities which you can measure or which you can demonstrate by imaging techniques or you can demonstrate by histopathology. Whereas the Cohen group, it relates to non-structural entities that cannot be defined either by imaging or by histopathology. Now, what are the specific causes for this abnormal uterine bleeding? So, if you have a polyp, you can resect the polyp. For adenomyosis, advise surgery in the form of a hysterectomy. Malignancy, you will either offer surgery and adjuvant treatments in the form of either high-dose progestogens or palliative radiotherapy. For coagulopathy, tranexamic acid and desmopressin are the drugs of choice. Ovulatory factors, lifestyle modification. If there is hyperprolactinemia, offer cabergoline. If the woman is hypothyroid, offer levothyroxine. For endometrial causes, you can offer specific therapies depending on what is the endometrial pathology. Okay, and the causes that are not yet classified, so if there is endometritis, you can give antibiotics. If there are AV malformations, embolization can be tried. This is another classification of fibroids that everyone should be aware of. So pause the video here and have a look at these fibroids. So class 0 fibroids are the ones that are pedunculated or intracavitary. Class 1 fibroids, less than 50% is intramural or most of it is in the cavity. Class 2 is more than 50% is intramural and very less of the fibroid is bulging into the endometrial cavity. Now class 3, it contacts the endometrium, that means it is 100% intramural, it is not bulging into the endometrial cavity. Type 4 is intramural, 5 is subserosal with more than or 50% which is intramural. 6 again is subserosal, but most of the fibroid is subserosal, less than 50% is intramural. 7 again is subserous and it has a peduncle, and other or 8 is, they could be either cervical or parasitic. And 2 to 5, these are all hybrid leiomyomas, depending on how much of the fibroid is intramural, how much is bulging into the cavity, or how much of it is subserosal. Now the next important topic is about ovarian cysts. So let us see a typical question. You have a 30-year-old woman who presents to the gynec clinic with pain in lower abdomen, which is more on the left side. Ultrasound shows a 5 centimeter simple ovarian cyst in the left ovary. Now the woman is worried that this could be an ovarian cancer because there is a family history. So what is the incidence of ovarian cyst being malignant in premenopausal women? Well, the incidence is 1 in 1000 as given in the guideline. Okay, and this incidence increases to 3 in 1000 at the age of 50. Let us come to management of ovarian cysts in postmenopausal women. So you have a 54-year-old postmenopausal woman. She has no complaints related to the uterus and ovaries. She underwent an abdominal and a pelvic ultrasound as she was complaining of colicky pain radiating down to the groin. At the scan, they found a 4 centimeter simple cyst in the left ovary. She was menopausal, so an RMI was calculated, which is 150. Now she was low risk for malignancy, so she was managed conservatively and she was asked to come back in 4 months for a repeat ultrasound. Repeat assessment after 4 months, she was asymptomatic. Ultrasound showed the same features in the cyst and RMI was 150. What will you do next for this woman? So the options are discharge from follow-up, consider intervention, repeat assessment in 4 to 6 months, refer to a multidisciplinary team or offer BSO. So the correct option is repeat assessment in 4 to 6 months because this is as per the algorithm that is given in Green Top guidelines. We will see the algorithm later on. Now you have another woman. She is 54 years old, postmenopausal, severe abdominal pain. So an ultrasound is done which showed bilateral ovarian cysts. The cyst on the left was 5 centimeters, cyst on right 4 centimeters. Both were multilocular but simple cysts. RMI was calculated and so it was 175. Now what would be the further management option for this woman? The answer here is consider a bilateral salping oophorectomy, mainly because she is symptomatic and she has bilateral ovarian cysts and they are multilocular and also her RMI is on the higher side. Okay, another scenario where you have a 72-year-old woman who is generally fit and fine. She is referred to you by the surgeons. She was admitted with left iliac fossa pain. A scan done shows uterus is normal size, ET is 3 millimeters. The left ovary is not showing any obvious mass. The right ovary has a cyst, simple cyst, which is measuring 3 by 4 by 4 millimeters. No free fluid seen and Ca125 is 16 international units per ml. How are you going to manage this woman? The correct option here is you will repeat a scan in 4 months. Why? Because she has a simple cyst which is asymptomatic. She has pain on the left side. The cyst is on the right side. So it means that in fact the cyst is actually asymptomatic. Now you have another woman, 54 years old, postmenopausal. She has been referred by her GP with vague symptoms of abdominal discomfort and bloating. Her abdomen is soft on examination. Pelvic examination shows that the uterus is atrophic, ovaries are not palpable. Transvaginal scan, there is a right ovarian cyst which is simple, unilocular, measuring 4 centimeters. No solid lesions, no ascites. Ca125 is 30. What is the best possible management for her? Let us follow up in 4 to 6 months. Why? Because if you calculate her RMI, it is less than 200 and the cyst is small, it is asymptomatic and it is simple. Okay, her RMI in fact is 0 because there are no ultrasound features and so you will follow her up in 4 to 6 months with a repeat scan and a repeat RMI calculations. If on ultrasound the cyst was showing any features like it was multiloculated, it was more than 5 centimeters, or the cysts were bilateral, then you would be offering her a bilateral salpingo oophorectomy even though the RMI would be less than 200. Now you have another woman who is 54 years old, postmenopausal, and she has an incidental finding on ultrasound of a right ovarian cyst which is multilocular. It is measuring 4 centimeters. There are no solid lesions. Mild ascites is noted. And her CA125 is 32. So what is her RMI score? Her RMI here is 288. To calculate the RMI, how will you do that? So you have to first know whether the woman is premenopausal or postmenopausal. What are the findings on ultrasound? And what is her CA125 level? So you have to multiply all of these and then you would get her RMI. Now women those who are postmenopausal, they have a score of 3. If they are premenopausal, the score is 1. So here this woman has a score of 3. Her CA125 is 32 and ultrasound is showing that she has a multilocular cyst which is 4 centimeter and there is mild ascites. Okay, so what are the ultrasound features that you are looking for? Okay, so if there is a multilocular cyst, if the lesions are bilateral, if there is evidence of any solid areas, evidence of metastasis or presence of ascites, each of these has a score of 1. But when there is a score of 2 or there are 2 ultrasound features, it is calculated as a score of 3. So here this woman has a multilocular cyst and there is mild ascites. 2 ultrasound features means ultrasound score is 3. So you multiply 32 into 3 which gives us a score of 288. Now sometimes you have women presenting with ovarian cysts, and there are some ultrasound features which help to differentiate between benign and malignant ovarian masses. So which one of the following feature is not a feature of a benign ovarian mass? A unilocular cyst, absence of acoustic shadowing, solid component which is less than 7 mm, there is no blood flow, or a smooth multilocular tumor with a diameter of less than 100 mm. The correct answer is absence of acoustic shadowing. The presence of acoustic shadowing is a feature of a benign mass. So the IOTA group ultrasound guidelines, which help us to define benign and malignant masses, give us some B rules and M rules. So these are the B rules and the M rules. Please pause the video and go through what are the B rules and the M rules, because this is important. You would be getting a lot of SBAs on this. Now coming to another scenario, you have a premenopausal woman, 35 years old. She presents with a complex ovarian mass. Which one of the tumor markers would you consider doing for her? Option A is lactate dehydrogenase, option B is HCG, option C is alpha fetoprotein, option D is A and B, that means lactate dehydrogenase and HCG. Option E says lactate dehydrogenase, HCG and alpha fetoprotein. The correct option is option A, that means you would be doing a lactate dehydrogenase, HCG and also an alpha fetoprotein. Okay, because in any woman, any premenopausal women, those who present with complex ovarian masses, there is a very high probability that these could be germ cell tumors, and LDH, alpha fetoprotein and HCG, they would be high in cases of women, those who have any germ cell tumors. Serum CA125 level need not be done in premenopausal women whenever you have a simple ovarian cyst, because serum CA125 level is indicated in postmenopausal women, because these women are more likely to have epithelial ovarian tumors. So coming to the algorithm for management of ovarian cysts in postmenopausal women. Okay, So any postmenopausal woman who has an ovarian cyst or she has a cystic lesion which is more than 1 centimeter or more. So for all these women, you will measure her CA-125 level, you will do a transvaginal or a transabdominal ultrasound and calculate the RMI. Whenever RMI is more than 200, there is an increased risk of malignancy. So do a CT scan of the abdomen and pelvis and refer the woman for a gynec MDT review, and there at the MDT review they would find out whether there is a high risk or a low risk of ovarian malignancy, and accordingly they would decide whether she needs a full staging procedure or she needs a pelvic clearance in the form of total abdominal hysterectomy with BSO, with omentectomy and peritoneal cytology by a suitably trained oncologist. Now coming to women, those whose RMI is less than 200. So here the risk of malignancy is very less. Now these women where RMI is less than 200 and they have cysts which fulfill all the following criteria. That means the woman is asymptomatic, the cyst is simple, less than 5 centimeters, it is unilocular and unilateral. For all these women, you will consider a conservative management. Where the cyst is not fulfilling any of these features, that means it is symptomatic, it is non-simple, it is more than 5 centimeters, it is multilocular or it is bilateral, you will consider surgery in the form of salpingo-oophorectomy, which is usually bilateral. Now, if you are offering conservative management for these women, so you will do a repeat assessment in 4 to 6 months in the form of repeating a CA-125 and again offering either a transvaginal or a transabdominal ultrasound. Now, if at the repeat assessment the cyst has resolved, the woman is discharged from follow-up. If there are any change in any of the features, okay, you will consider intervention. But if the cyst has remained persistent or there is no change, you will do a repeat assessment in further 4 to 6 months. If at the repeat assessment it has resolved, you will discharge her from follow-up. If there is any change, you will consider an intervention. But if at the second follow-up the cyst has remained the same, you will individualize treatment after a thorough discussion with the woman. The next important topic is now about menstruation. Okay, any abnormalities of menstruation either in the form of precocious puberty, delayed puberty or amenorrhea. Before that, let us have a quick revision or have a look at the physiology. So we all know that the hypothalamus is the main organ which is at the head. From the hypothalamus you get release of GnRH which acts on the pituitary. The pituitary releases FSH and LH. This FSH and LH acts on the ovaries. The ovaries release oocytes and they also release progesterone and estrogen, which is responsible for the menstrual bleeding. Puberty changes usually start at the age of 8 to 12 years. The first change that is seen is thelarchy, second is adrenarchy and then menarchy. It usually takes about 2 to 2.5 years since onset of thelarchy to menarchy. Now let us see menstrual dysfunction. So the mean age at menarchy should be 13 years. Cycle length is usually 21 to 45 days in adolescents. What would you call as primary amenorrhea? So whenever there is no development of any secondary sexual characters after 13 years, it is considered abnormal and you would start investigating this girl. Now any woman or any girl who has primary amenorrhea with development of secondary sexual characters after 15 years, even this is abnormal. So any girl with secondary sexual characters, primary amenorrhea at 15 years, start investigating. Any girl at 13 years without any secondary sexual characters presenting with primary amenorrhea, start investigating. Now you have to be very careful not to make a diagnosis of PCOS in those who are less than 8 years of age. Why? Because there is a very high incidence of multifollicular ovaries at this stage, and if at any time you see like the woman is or the girl is coming with any signs and symptoms, you will offer her only conservative management in the form of lifestyle intervention. And only after she becomes 13 or 14 years of age, then you would consider other lifestyle or other management in the form of metformin or combined oral contraceptive pills. So first let us see precocious puberty. Now what is the definition of precocious puberty? Whenever you have appearance of secondary sexual characters before the age of 8 in girls and 9 years in boys, the classification is a little bit different for Afro-Americans. So for Afro-Americans, appearance of secondary sexual characters before the age of 6, you would say it is precocious puberty. For white girls, less than age of 7. Now precocious puberty, you have two types, central and peripheral. So depending on GnRH dependency, in central it is GnRH dependent, peripheral is independent of GnRH levels. Levels of FSH and LH are increased in those who have central precocious puberty, whereas they are not raised for those who have peripheral. The causes for central precocious puberty are either tumors in the CNS, trauma to the CNS, malformations, or most of the times it is idiopathic. Causes for peripheral are tumors of the ovary or the adrenals. It could be iatrogenic, and other syndromes like McCune-Albright syndrome. Now types of central precocious puberty, it could be isosexual or it could be contrasexual. Peripheral also, it could either be isosexual or contrasexual. Management of central precocious puberty, GnRH analogues are prescribed to desensitize the pituitary and suppress the levels of FSH and LH. For peripheral, it would depend upon the cause. So if there is a tumor of the ovary or the adrenals, surgical resection would be the ideal treatment. Now coming to delayed puberty. So it could either be constitutional or you could have various causes like hypogonadism, where there is absence or incomplete development of secondary sexual characters up to the age of 16. It could be hypogonadotrophic hypogonadism, where Kallmann's syndrome is the most important, where you have anosmia plus hypogonadotrophic hypogonadism. That means very low levels of gonadotrophins. The causes of hypogonadotrophic hypogonadism could be tumors, it could be drugs, any inflammatory cause or systemic disorders. Hypergonadotrophic hypogonadism could be another cause for delayed puberty, where there is intrinsic defect in the gonads. The most common cause of this is premature ovarian insufficiency or any radiation therapy to the ovary. Any girl coming with delayed puberty, you have to do a detailed physical examination. You have to inquire about the level of exercise, because very heavy exercise could lead to hypogonadotrophic hypogonadism. Or find out whether there is any dietary restriction, which again points out to a hypogonadotrophic hypogonadism cause for the delayed puberty. Find out about the ability to smell. If there is anosmia, it points to Kallmann syndrome. Now coming to the investigations. So you have to do the hormonal levels, do FSH and LH imaging to find out the outflow tracts, have a look at the uterus and the ovaries, and karyotyping if levels of FSH and LH are very high. So treatment for delayed puberty, you first initially add estrogen for 12 months. When breakthrough bleeding appears, you can add progesterone. The aim is you want to have a few pubertal development, reduce psychological consequences and achieve optimal bone mass. Now let us see a few questions about amenorrhea. So you have this 15-year-old girl which is brought by her mother since the girl has not attained menarche. The mother is very worried since the girl has suddenly started growing tall. On examination you see breasts are well developed, also pubic and axillary hair is present. So what will you do? Well, here you will not do anything. Wait for some time because as you can see the girl has started developing secondary sexual characters. So it would be prudent to wait for a period of 1 year. If the girl still doesn't present with menarche, you would start investigating her. Another scenario would be a 14-year-old girl brought by the mother. The girl has still not attained menarche. She is short for her age, no breast development, no pubic or axillary hair. What would you do here? Now here obviously there are no secondary sexual characters present. So here, even though she is only 14 years of age, you would still start investigating her for her cause of amenorrhea. So this brings us to what is amenorrhea. Amenorrhea means absence of menses. It could either be primary or secondary. Primary means no development of secondary sexual characters and amenorrhea by 13 years of age. Or it could be presence of secondary sexual characters and amenorrhea at 15 years of age. And secondary amenorrhea means absent cycles for 3 months in any woman who has previously normal cycles, or absent cycles for 6 months in any woman who previously had irregular cycles. Now causes for amenorrhea. It could be either endocrine causes, it could be primary ovarian insufficiency, it could be CNS disorders or genital tract abnormalities. Please do not forget pregnancy, breastfeeding or contraception as important causes of amenorrhea. Now what is the pathophysiology of amenorrhea? So whenever you have a central cause, there could be a defect in the hypothalamus and the pituitary. So there are defects of GnRH secretion leading to low levels of FSH and LH and absent ovulation. In the pituitary, it could be adenomas leading to pituitary dysfunction. Sometimes it could be Sheehan's syndrome leading to panhypopituitarism, or it could be hemochromatosis in patients with hemoglobinopathy. Lymphocytic hypophysitis or autoimmune disease are some of the rare causes of a central cause for amenorrhea. Ovarian causes. Infrequent causes among these are gonadal dysgenesis or primary ovarian insufficiency. Among these, primary amenorrhea you could be having with Turner's, where the karyotype is 45XO, or you could be having gonadal dysgenesis, that is Swyer syndrome, or you could have someone with a karyotype of 46XX. Now, premature ovarian insufficiency, it could either be an autoimmune cause or it could be due to radiotherapy or chemotherapy, or it could even be due to Fragile X syndrome. Ovarian resistance because of enzyme deficiencies could also be an ovarian cause for amenorrhea. Now, genital tract abnormalities. The most common among this is Mullerian agenesis, in which absence of the uterus in the presence of a normal karyotype, we call that as MRKH. You could have AIS with a karyotype of 46XY, or you can have vaginal defects, that means a transverse vaginal septum, or you could have an imperforate hymen. Now coming to the diagnostic workup for primary amenorrhea. So primary amenorrhea with absent secondary sexual characters, the first investigation that you would do is do an FSH. Whenever the FSH is less than 20 international units per liter, So you would do a bone age to see whether it is normal. If the bone age is normal, that means, and FSH is very low, it indicates that there is a hypothalamic pituitary dysfunction because levels of gonadotrophins are very less. The second is you have to take a complete medical history to know whether there is any chronic illness, whether this girl has been on any therapy or she has any CNS disorders. It's also very important to do the bone age because you would want to know the exact age of this girl to decide whether she has really primary amenorrhea. Now, whenever FSH levels are more than 20 international units per liter or LH is more than 40, check the karyotype because the cause of amenorrhea could be a genetic disorder. Secondly, you also have to check if the karyotype is normal, whether there is ovarian insufficiency. Now, the next important thing after the investigations, you will do a history and you would examine the girl. So whenever the uterus is absent, you do a karyotype. If the karyotype is 46XY, it indicates it is androgen insensitivity. If the karyotype is normal, that means it is 46XX, it is Mullerian agenesis because the uterus is absent. Whenever the uterus is present, check for an outflow block. If it is present, if there is imperforate hymen or there is a transverse vaginal septum, you need to do surgery accordingly. If there is no outflow block, then you have to evaluate for causes of secondary amenorrhea. So whenever you are evaluating for secondary amenorrhea, serum beta HCG or urine pregnancy test. Remember that pregnancy is a very important cause and do not forget. If it is positive, you have already got your cause for secondary amenorrhea. If beta HCG is negative, then you have a look at the phenotype whether there are any dysmorphic features, take a complete medical history and do FSH levels. If FSH levels are raised, it could indicate that it is premature ovarian insufficiency if the age is less than 30 years. In these cases, go ahead and do a karyotype, or if you get FSH levels that are normal, you need to look out for any outflow tract abnormalities. Now, what are the treatment options? So, whenever you have primary amenorrhea and there is absence of secondary sexual characters, you first start with conjugated estrogens, and after 1 year, you can add progesterone. Whenever you have an abnormal karyotype, you have to go ahead and do a gonadectomy because there is a high risk of malignancy developing in these gonads. Whenever there is congenital adrenal hyperplasia, corticosteroids have to be replaced. In case of pituitary tumors, either a medical or surgical option is there. And if there is a hypothalamic cause, cyclical gonadotrophins or GnRH has to be replaced. Now, in women with secondary amenorrhea, you need to give HRT to prevent osteoporosis. Combined oral contraceptive pills or conjugated estrogens followed with progesterone can be given to induce a regular cyclical bleeding. You have to advise these women to put on weight whenever you find that there are symptoms of anorexia nervosa or there is sudden weight loss. Treat thyroid. Look out for thyroid function. If it is abnormal, treat the thyroid dysfunction. Look for PCOS. Look out for prolactinomas. If they are present, you can give dopamine agonists. And always do not forget to screen for adult CAH. If there are outflow tract abnormalities, imperforate hymen, surgical management is the treatment for that. Let us have a look at some of the causes for amenorrhea. In the picture A, you see this girl, apparently normal looking, with presence of secondary sexual characters, normal height, If you have a look at her karyotype, it is normal 46XX. So what could be the diagnosis here? Since the karyotype is normal and she has no dysmorphic features, the likely diagnosis is Mullerian agenesis because she has presented with primary amenorrhea. In picture B, you have this woman. Her stature is normal for age, breast development is normal, she has no axillary hair. In the abdomen, there is a mass which is felt in the left groin. No other abnormalities are noted. Rectal examination is normal. Scanty pubic hair, intact annular hymen, and no other abnormalities. But if you have a look at her karyotype, it is showing 46XY. So this points to a diagnosis of complete androgen insensitivity syndrome because her karyotype is 46XY. Androgens are not acting, so she has the phenotype of a female and the mass that is there in the groin, that could be the gonads. Now another girl who presents with either primary amenorrhea or secondary. Short stature, webbing of neck is seen, hairline is low posterior, she has heart defects in the form of coarctation of aorta. The chest is broad, widely spaced nipples, she has cubitus valgus. Ultrasound shows that ovaries are streaked, she has infertility, amenorrhea, and she has peripheral lymphedema at birth. If you have a look at her karyotype, it shows 45XO. Now this points to a diagnosis of Turner syndrome, which is seen by the typical features or the dysmorphic features that you can see in this girl. So these were some of the important topics for general gynecology. Thank you for watching this video and I hope you found the video helpful. Thank you once again and good luck for your exams.